And as far as the final concern, I don't have any confirmation from the administration about the final. Looks like maybe on the Zoom. Everybody, we don't want anybody in person over here in the final. It looks like 80% goes in that favor, or 20% comes up. So most probably will be on the Zoom. So we don't want 60 students over here. Is it clear? So I will announce on Canvas. So whatever the final decision comes. Okay, so let's start the discussion, chapter 33. And also, by the way, I emailed a couple of students to take care of pending assignment. When the date is closed, nothing I can help. So, a couple of students I emailed to take care of your pending assignment before it's too late. Okay, so let's talk about the chapter 33. First thing is over here, we're talking about the disorders of the kidney. This disorders of the kidney, we discuss in 4 broad headings. If you look at that one, subjects to many of the same types of disorders that affect other body structure, like what? Developmental defect, like what? Infection, like what? Immune, like what? Neoplasm. Is it clear? So those are the 4 headings we have to take care for kidney disorders also. Now, developmental defect, like now we are talking about the fetal anomalies. Most common anomalies in shape and position. In terms of shape, kidneys two kidney, right and left kidney in their own location. Sometimes the lower pole of the kidney, because of the fetal anomalies, they are joined. And we call that 2 kidney when joined at the lower pole or the upper pole, we call horseshoe-shaped kidney. It is not in the PowerPoint, but it is in the textbook. We call horseshoe-shaped kidney. Horseshoe-shaped kidney. If you look at the horseshoe. Or in some location, in some places, the kidney displaced, not in their normal anatomical position. So these are the most common anomalies in terms of shape and position. Less common, please remember, less common disorders involve a decrease in renal mass. Renal tissue is less developmentally. We are going to discuss in terms of agenesis, in terms of hypogenesis, dysgenesis, and so forth. Number two is change in renal structure. Sometimes the renal tubule supposed to be tube shaped to perform their function. Instead of that, they are turned into small cysts that we call renal cyst. Maybe dominant or maybe recessive. The most common is dominant, and one of these features we're going to discuss, that's called Porter syndrome. Porter syndrome. We're going to discuss renal cyst. Now, which is less common, but all important, so all board, it's called number 1 called dysgenesis. What is dysgenesis? It is a failure of an organ to develop normally. That's called dysgenesis. What about agenesis? Agenesis means a complete failure of an organ to develop. It's not here. Next is called hypoplasia. Hypoplasia is a failure for organ to reach its normal size, not completely developed. I just mentioned about the Porter syndrome. This is the one. Please make a star and remember, these Porter syndrome babies They have characteristic facial features. They have characteristic facial features with due to the cause is renal agenesis. Because my kidney during development by 12 to 13 weeks of my age in my mother's womb, they start working. I start peeing in my amniotic fluid. And that kidney is not developed. As a result, the kidney is not functioning, urine is not coming out from the kidney. As a result, the fluid around the embryo fetus is less, we call amniotic fluid. Amniotic fluid is less, and because of the less amniotic fluid, that causes a pressure effect on my body. Because the uterus is pressing, mother uterus pressing on my delicate structure. And as a result, I'm having my abnormal facial feature, abnormal limb, kidney is not there. So that's called Porter syndrome. And the cause is my agenesis of the kidney. Remember all those features? Number one, eyes are widely separated and they do have epicanthic fold. Number one. Number two, ears are low set ears. The nose is broad and flat. Chin is receding. And they do have these newborn, they do also have limb defect along with renal agenesis. So the causes of neonatal renal failure with Porter syndrome causes maybe cystic renal dysplasia, obstructive uropathy, autosomal recessive polycystic disease, unilateral agenesis, which is uncommon, has to be bilateral. Now, cystic disease of the kidney, this is another broad heading. Cystic disease of the kidney. What do you mean by cystic? The definition is a fluid-filled sac. Please remember, cyst is a fluid-filled sac or segment of dilated nephron or renal tubules. Causes may be tubular obstruction that increases intratubular pressure that leads to formation of cyst. Next, changes in the basal membrane of renal tubules that predispose to cystic dilation. These patients, even though they have that things in the kidney, when they're grown up, they do have intermittent flank pain. I have discomfort in the flank. Or I have repeat history of urinary tract infection. Or sometimes my urine has blood. Is it clear? So these are the features with renal cyst or kidney, cyst of the kidney. And the condition over here most common is we call autosomal dominant polycystic kidney disease. Autosomal dominant polycystic kidney disease. What is the cause? Probable cause of autosomal dominant, which is coming in the textbook also. Autosomal dominant polycystic kidney disease, where the cells of my renal tubule, epithelial cells of the renal tubule, they multiply profusely and lead to the formation of cyst in my kidney. That lead to cystic dilation. The one I just said is the last one, over here in the polycystic kidney disease, autosomal dominant polycystic kidney disease, ADPKD. Autosomal dominant polycystic kidney disease. We do have autosomal recessive, but autosomal dominant is more important. Now, the types of cystic disease of the kidney, we do see in the textbook, they do also have the diagrams. There are 5 different types. 5 different types on page 984. So there's a diagrams of all these types of cysts. Number 1, simple and acquired renal cyst. Number 2, medullary cyst. And then we do have polycystic kidney diseases. One is autorecessive, the other one is dominant. I did mention how those patients with cystic disease present. And I said intermittent flank pain, history of repeated UTI, urinary tract infection. Also, in some cases, they do have a history of hematuria. Hematuria means the passage of blood in the urine. So all those features, then we do perform the X-rays, ultrasonogram, confirm whether they do actually they have a cyst or not. Okay. Now, the causes of urinary tract obstruction. The important. Please remember, these are over here. There are some of them. Over number 1, if we call developmental defect, that causes obstruction. Number 2, formation of stone, we call calculi. Pregnancy, in some females, they do have obstruction in late-term pregnancy. Late-term pregnancy also lead, not only late-term pregnancy, if the fetus is, maybe mother is suffering from diabetes. So pregnancy also causes urinary tract obstruction. Please remember, in male, benign prostatic hyperplasia, 60 up, most of the male, they do suffer from prostatic hyperplasia. Or the TV, if you look at that one, they do say DPS. Benign prostatic hyperplasia, they sell medication for DPH. So it is one of the common cause of urinary tract obstruction in old people. They have difficulty in urination. And obstruction of the flow of urine also lead condition we call UTI, urinary tract infection, because of the obstruction. Which part of the urethra is compressed? Urethra is compressed because of the enlarged prostate. It is my prostatic urethra is compressed. Prostate is getting enlarged because if you remember the prostate, I said it's a normal anatomy, shaped like a donut, size like a walnut. Shaped like a donut, size like a walnut, size like a walnut. This prostate, when they're becoming enlarged in size, hypertrophy enlarged in size, they compress my prostatic urethra. That causes obstruction. Okay, so please remember, now we do have scar tissue resulting from infections, repeated infections and inflammations. We do have tumors, maybe benign or maybe malignant. Neurologic disorders, such as spinal cord injuries. Also, people with suffering from Parkinson's disease, people suffering from multiple sclerosis. Multiple sclerosis, please remember, they do suffer from urinary tract obstruction because the bladder becomes neurogenic because of MS, multiple sclerosis. Please remember. Okay. Now, damaging effect, obstruction occur. Stresses of urine, because of the obstruction, urine becomes stagnant, and that lead to or predispose to two things over here. One is UTI, the other is stone formation. Obstruction lead to UTI, urinary tract infection, and predispose to stone formation. Both are important. Now, developmental back pressure interferes with the renal blood flow and destroys kidney tissues also. We call urinary backflow. Stresses of the urine, stresses of urinary obstruction, all lead to urinary tract infection. Now, manifestation of urinary obstruction, how patient present if they do suffer from urinary tract obstruction. It depends on number one, site of obstruction. It depends on the cause, and number three, it depends on the rapidity with which the conditions develop. These are the factors we need to keep in mind. But normally, these patients present the symptoms of pain. Please remember, pain. We also call pain during micturition. We call dysuria. D-Y-S-U-R-I-A. Dysuria. Painful micturition. Now, they do also suffer from signs and symptoms of UTI, maybe fever, urgency, frequency. Sometimes they get up at night. We call nocturia. And manifestation of renal dysfunction, all those maybe dehydration, electrolyte imbalance, or maybe edema will happen. Kidney stone, please remember kidney stone, or we also call calculi. By definition, these are crystalline structures that form from the component of urine. These are crystalline structures which are formed from the components of the urine. In the urine, they do have some chemicals that lead to formation of nidus or nucleus, on which all those chemicals they start sedimenting. That lead to formation of stone. So the requirement for formation, they need to have a nidus, or we can say nucleus, on which those chemicals will settle to form a stone. Number two, urinary environment that supports continued crystallization of stone component. Normally, urine is acidic. Sometimes there are some chemicals which make alkaline, and that also predisposes to stone formation. So please remember the factors influencing the formation of kidney stone or renal calculi. Number one, the concentration of stone components in the urine depends on the concentration of stone components in the urine. Number two, the ability of a stone component to complex and form stones. Number three, the presence of substances that inhibit stone formation, that goes down and the chemical which forms stone, they go high, increase in concentration. All these factors, except one, please remember, all these factors, A, B, and C, these three factors predispose to stone formation. Except the last one over here, which is not, which is a high sodium concentration. If I eat too much salt, it's not going to make or help in the development of stone. But my pH, my supersaturated urine become concentrated, or stasis or obstruction in the flow of urine that lead to stone formation. So which of the following condition does not lead to stone formation? I said except D, all of the above. Okay. Now, in terms of types of stone, we do have 4 different types of stones which usually develop. Most common stone is calcium oxalate stone. Calcium oxalate or calcium phosphate. These are most common. We do by doing a plain X-ray of the KUB region, kidney bladder region, we can see those stones. Calcium oxalate stone. Then we do have MAP, we call MAP, magnesium ammonium phosphate stone. You have the name we call staghorn calculi. The third one we call uric acid stone, and the last one is cystine stone. But calcium stones are more common. Calcium stones are more common, followed by magnesium, followed by uric acid, and then cystine stone. So in order to not to have stone, we do use some preventive measures, some dietary restrictions. If somebody diagnosed with calcium stone, listen carefully. If somebody diagnosed with calcium stone because they did IVP, intravenous palligraphy, they said you have a stone and report comes with calcium stone, and patient need to be prepared for the surgery because the stone is big. Sometimes the stones are small, they can be removed without surgery. But in order to prevent the further development of the calcium stone, patient need to be advised. That patient need to be advised, can you cut down your chocolate? I can't live without chocolate. No, you need to cut down your chocolate. You need to cut down your cocoa. You need to cut down spinach. Those are the things, restrictions are given. If you prevent those, you'll be in good shape. Is it clear? But in the meantime, we will try. If the stone is small, without surgery. If the stones are big, then surgery is recommended. So in the meantime, you need to advise patient, please cut down your cocoa, your chocolate, your peanut, all those nuts that might enhance the size of the calcium oxalate stone. So to prevent that size, so we advise those patients. That's what I said, preventive dietary restriction, calcium salt supplementation, thiazide diuretics, which is water pill, and cellulose. Patient suffering from pain, we need to prescribe some pain medication. But those pain medication, we need to be careful whether they do have Some, like most common is ibuprofen. Ibuprofen is an Advil. That ibuprofen or Advil, they do have a nephrotoxic effect. Everybody clear with that one? Advil, I'm taking Advil. I keep everything all the time, I keep Advil. But we need to know if I take Advil in required amount, required dosage, and with food, I'm okay. Provided my kidneys are healthy. If I'm suffering from kidney disease, I'm taking Advil for my pain because I have to work outside in the yard and whatever my job. But on long run, I'm damaging my kidney. The kidney is already damaged. By taking Advil or the painkiller, we need to remember those painkillers, whether they do have damaging effect on the kidney or not. That's the important. If the patient has UTI, urinary tract infection, some antibiotics are prescribed. Most common antibiotics, please remember, we call Bactrim, BACTRIM. Most common, it's cheap, very cheap medication, but very effective medication. Bactrim. This is one of the antibiotics, randomly prescribed, very effective. The other is Cipro, very common also, Cipro. And the third one is levofloxacin. Levofloxacin, Cipro, and Bactrim. These are the antibiotics randomly prescribed for UTI, urinary tract infection. But some of the antibiotics, some of the other antibiotics, which is also prescribed, which is effective, but we need to give an appropriate dose according to patient age and weight. Age and weight. Commonly prescribed, that is also called write down gentamicin. GENTAMYCIN. Gentamicin. It's very effective antibiotic, but they do have some nephrotoxic effect. Everybody's okay with the nephrotoxic effect? That means what? Damaging effect. They have some damaging effect on the kidney, but sometimes we do need, because my culture report, lab report said I have this organism, and they said this organism needs gentamicin. Is it clear? So gentamicin. Same thing with non-steroidal anti-inflammatory drug. Sometimes we do need to get relief from the pain, but we need to be careful that if I take too much Advil, that might also have a damaging effect on my kidney. Okay. Now, removing stones, either by uteroscopic removal, percutaneous removal, or extracorporeal lithotripsy. Now, diagnosis for the stone, we do need to perform the urine analysis. Please remember. And most common bacteria also, the stone, we can see those chemicals. For urine analysis, we do see most common microorganism or bacteria is E. coli. E. coli is most common bacteria which leads to my urinary tract infection, and that urinary tract infection lead to stone formation also. Radiography, plain X-ray, intravenous pyelography. I mentioned about intravenous pyelography. Is that correct? IVP. we call IVP, intravenous pyelography. I mentioned this one, intravenous pyelography, with my calcium stone. They found with IVP that I have this stone, so I need to get ready for surgery depending on the size. Now we do perform ultrasonography to see the location of the stone also. Size of the stone, location of the stone, number of the stone. Oh, right over here now. Okay. So types of urinary tract infections. Asymptomatic, no symptom, but still I am suffering from urinary infection. Asymptomatic bacteria. Number two is symptomatic, maybe pain, maybe fever, maybe pain during micturition. We do have urinary bladder, infection of the urinary bladder that is called cystitis. Please highlight cystitis. Infection or inflammation of the urinary bladder we call cystitis. Female are more prone. And the next, which belongs to my lower urinary tract infection. We do have upper urinary tract infection, which involves my kidney tissue or renal pelvis and others. Pyelonephritis. Most common patient with pyelonephritis, they usually present with pain and also fever. Fever is I'm feeling chill. My temperature shoots up. Having pain in the flank region and having painful micturition. And they did urine analysis. They found the bacteria and they said they confirmed that this is pyelonephritis, so we need to take it. So most common presentation for the pyelonephritis is high fever and chills. Please highlight the causes of UTI. Most common, I mentioned earlier, most common uncomplicated UTI in his mind are E. coli, caused by E. coli, Escherichia coli. The others, uropathic pathogens includes Staphylococcus, Saprophyticus in uncomplicated. These are the other organisms. And most caused by bacteria that enter the portal of entry is my urethra. Port of entry. So personal hygiene is the important. Personal hygiene is the important. We need to make sure the area is clean, not especially female, because the urethra, size of this urethra is small and is close to the perivaginal area. And the bacteria grows. We need to keep that area clean because urethra is the most common port of entry, which might lead to UTI. Start from cystitis. If a female patient giving you history of bragging that I don't need to go to the bathroom, I'm okay for 8 to 10 hours without going to the bathroom. But that patient might, in long run, might suffer from cystitis. She's is most likely candidate for cystitis. Everybody clear with that one? If I say, I told my nurse that I'm okay, I don't need to go to the bathroom. My job is, I don't have a restroom or there, I'm okay. I go work, come back and use that. But you are making yourself, the patient is making yourself susceptible to cystitis. Everybody's clear with that one? We need to flush. We need to flush. Okay. The causes of UTI associated with stasis of urine flow. Number one, anatomic obstruction. Number two is functional obstruction. Now let's take care of anatomic obstruction. Anatomic obstruction might be caused by urinary tract stones. Please remember, stones, then person most common in person with a person who is age 60 and up, their history of enlarged prostate that might lead to stasis, that might lead to infection. Pregnancy also, late-term pregnancy, predisposed to obstruction, and there may be some malformation of the utero-vesical junction. If it is below the utero-vesical junction, both the kidneys are involved. It is above the utero-vesical junction, then one kidney is involved. That lead to increased pressure resulting in reflux. Urine is backflowing because of the obstruction. Functional obstruction. I did mention this one with neurogenic bladder. I mentioned with suffering from multiple sclerosis. Now I do have a neurogenic bladder. Difficulty passing urine. Urine flow is obstructed because I'm suffering from multiple sclerosis. Number two, if you look at that, infrequent voiding. I give the history of the female that she doesn't need to go to the bathroom for 8 to 10 hours. Infrequent voiding. Then we do have due to some muscle instability. Sometimes people they do have constipation. Hard stool in the rectum obstruct my flow of urine. Is it clear? Hard stool, which is constipation, lead to functional obstruction. If I take care of this constipation, I'm fine. Because of this hard stool in my rectum causing obstruction of my urethra, especially in female. We do have, as a human being, we do have a protective mechanism. Number one is washout phenomenon. That's why it's the flush the kidney, flush the kidney. More you drink, more you flush. We do have mucin layer because of the urine bladder. They do have protective chemicals. Local immune responses, normal flora of the periuteral area in female, and also this in male also, prostatic secretion also have a protective mechanism. Okay. Now, it is about the acute episodes of cystitis. Frequency of urination as often as every 20 minutes. Visit bathroom. Lower abdominal or back discomfort. Number three, burning or pain on urination, please highlight the term that's called dysuria. Dysuria. Or the urine, which is coming out, urine may be cloudy, may be bloody. Make a note about there, may be cloudy, may be bloody, foul smelling or strong smell of the urine that lead to something is going wrong in my urine, which is start from the cystitis over here. And it is clear. So those are the presentation, frequency, urgency, with or without incontinence. Nocturia is not mentioned over here. Nocturia, patient need to get up at night and go to the bathroom. Can't hold it because the bladder is inflamed. Okay, so please put a star mark and remember on all these presentation, patient with cystitis or urinary cystitis, or I can put under the umbrella of UTI, urinary tract infection. We need to take a history of the patient, especially those who are sexually active female. They are prone to have UTI, single partner, multiple partners. Number 2 is pregnant woman. And the age of the patient is important also. Elderly, if you look at the elderly male, maybe he's having a life posture. And also, folks, we need to be careful, especially in elderly, when we are prescribing any medication, because we need to know this is your age. I need to be a little bit careful on prescribing a medication, because if I prescribe a regular dose, I might damage your kidney. Your kidney is already in depth, is not a good shape. So I need to be careful because you have this range 60 plus. Is it clear? So older adults are susceptible to kidney damage, especially in old age. Okay. Diagnosis and treatment of UTI. So how we diagnose? Diagnosed based on the symptoms, patient presentation, and on examination of the urine for the presence of microorganism. Most common microorganism, I said what? E. coli. Very good. Now, we do have a tool, not only urine examination, we do perform X-ray. Number 2, ultrasonography, CT scan, used to identify contributing factors. Urine dipstick tests are there, very handy. Put the urine on with the dipstick, changes the nitrite. And the treatment of UTI is based on the causative organism. Causative organism. According to that causative organism, we do have antibiotic. Question: is the following statement true or false? Static urine flow will predispose your patient to development of UTI. Urine is static. Yes. Static urine flow will predispose for patient for development of UTI. And also, sometimes these patients they have, they do have sometimes that we call urinary retention. Urinary retention. I'm going in the bathroom. I'm done, but I'm not satisfied. After 15-20 minutes, I need to do again. This is because I might have something in my bladder. My bladder is not completely evacuated. That is called urinary retention. Everybody's clear with that term? Urinary retention. The urinary retention, the urine is still, I'm voiding, but still is not, I'm not satisfied. So we need to perform, the nurse need to perform that, attending nurse or physician, they need to perform the ultrasonography to see the condition of the bladder and ask the patient to urinate. And what happened after voiding, after urination, is there still some urine in the urine bladder or not? If it's there, that means my diagnosis confirms the patient suffered from urinary retention. So how? By doing ultrasonography. And ask the patient to urinate. And after voiding, we see some collection of urine in the urinary bladder. And what is there? Folks, let's have a break. This is a different topic. I will stretch out. Returning time is 10:15. I'm going to be a bit tight today. So 10:15 returning time. Zoom, 10:15 will come back.